Thanks for joining us today at the Risk Adjustment Integrity Group. We are a joint venture brought to you by Health Administration Advisors and Advize Health, with analytics supported by Infinity Healthcare Analytics. The main goal of our integrity group is to keep risk adjustment on track. We are a national advisory for health plans, as well as risk adjustment vendors, providers, accountable care organizations, risk adjustment educators, and leaders in the space. You can reach out to us directly at our Contact Us email below. Okay, so for today, we're going to cover the following topics. We're going to talk a little bit about why risk adjustment was created in the first place. We're going to talk about the importance of understanding the difference between paying for claims that were encounters treated in the past as opposed to how we fund for health plans to be able to pay for those claims in the future. We're also going to take a closer look at the MEAT acronym and talk about its origins a little bit. And then we're going to talk about challenges of building coding teams, and we'll talk a little bit about retrospective chart reviews as they exist today and the history of how we got here. And then we're going to talk about the importance of applying national standards. We're also going to share some secrets and tools with you, and our goal here is to unify risk adjustment educators so that we are all talking the same language and using the same processes. Okay, so why was risk adjustment created in the first place, right? Well, before risk adjustment, we just had a fee-for-service model. And remember that in a fee-for-service world, we're only getting data as it relates to diagnoses or procedures that were performed in the past. Each incoming claim is for encounters that have already taken place. But when you look at population health programs, you can see that when we know what conditions people have, we become empowered with that health data. We're not just waiting for a manifestation or a complication or some encounter or visit to occur to just then pay for that and wait for the next problem to happen. The goal in healthcare is to provide better care, more proactive care. So our goals include things like minimizing the need for emergency room visits and hospital stays. Both of these are very costly. There are many instances where patients, when more proactively managed, can minimize or even mitigate complications or manifestations of their current known conditions. Health plans have disease management programs and many developing efforts to improve healthcare delivery, but it is impossible to enroll a patient in a disease management program if you aren't aware that they have the diagnosis in the first place. The key to getting ahead of them is by knowing that they exist. And we know very specifically by diagnosis code how much the average costs are to treat patients for various illnesses or problems. There are studies done all the time about the treatment of certain surgical interventions and which ones of those procedures require more work and or have fewer complications. And likewise, on the diagnosis side of the house, we know, for example, the differences between treating a diabetic without complications versus one with CKD or retinopathy and how much more that costs once those manifestations or complications develop in the patient. It's important that diagnosis coding is always reported as specifically as possible, of course. And the diagnosis codes reported, whether they come from a claim for treatment or from a retrospective review for supplemental diagnostic data, in either case for risk adjustment purposes, this is so that we can become more proactive in our healthcare efforts. The HCCs that are picked up when the diagnosis codes are left behind actually build a hierarchy for the patient that's tailored specifically to his or her known conditions. Not just those that are treated, but all of the conditions known so that we can get ahead of any complications or manifestations wherever possible. And we might even recognize new treatment regimens or potential new solutions that we need to come up with because of disparities in certain groups of people, whether that be their socioeconomic status or their geographical location. We might discover a need to develop new practices altogether for new conditions, such as COVID and the long hauler symptomology, which can be different from patient to patient, as well as the documentation of any reactions to vaccines people have gotten. We have to study these things for population health purposes. This is a new approach to population health that's meant to feel and look different from what we've been doing for many, many years. Most of you probably have been following along on the posts and articles that we've been sharing publicly about the importance of getting risk adjustment right. And one of those articles focused on this particular topic in particular, where we really wanted people to identify that there is a difference here in how you pay for a claim and what rules apply to the coding of those claims or encounters, as opposed to funding of health plans for population health purposes. We'll talk a little bit more about meat in a couple of slides ahead, as well as its history, but I want you to keep in mind that paying claims is a situation where we're paying for something that's already occurred, first and foremost, and funding for health plans has to do with planning. What do we anticipate may be happening or might come to fruition for the patient based on what we know today? These two tables, in fact, are taken from that article that I was referencing on the last slide. We want people to remember that retrospective payments are made related to a relative value unit of work that was done in the past. So the provider should be only taking credit for the diagnoses that they treated on that past encounter and not be able to increase their retrospective payment just because of additional diagnosis codes. And that's really why the MEAT acronym was created in the first place. And we'll talk a little bit more about that. This is very different from, the way that the provider codes and documents from how health plans have to look at population health. Population health and risk adjustment models were created for prospective funding, to be proactive in care. And that's not just related to those retrospective claims or encounters that took place with those things that were treated in the past. We have to know what the future needs of the patient are going to be. And people should keep in mind that diagnosis codes, whether they come from those claims, from those retrospective payments, or if they come from a supplemental diagnosis code review, the diagnosis codes and risk adjustment are actually dropped. And what's kept is the associated HCC, the hierarchical condition category, so that we can estimate our funding and understand what might be coming down the pike for patients based on their individualized profile. So again, just one more time and with an extra little picture here for the people in the back, let's keep in mind that diagnosis codes are dropped for HCCs and risk adjustment, and those diagnosis codes come from two main sources. One source is from claims data from encounters, whether that was inpatient or outpatient, and yes, it has to be a particular provider type, and there are certain claims that are left out of the mix because we only want to include diagnosis codes that we know are valid. It's not we're including only the ones that were treated. Our goal is to include the ones that are valid. Secondly, we also are allowed to add supplemental diagnosis codes when we do retrospective reviews on those visits. So if the provider had other chronic conditions listed in the medical record that maybe wasn't treated on that visit, but it's an ongoing chronic problem, it's obvious from the documentation the patient still has this condition, then yes, they're supposed to be picked up. They're not being added to the encounter or visit. They're being picked up as supplemental diagnosis codes. Whatever the provider submits on their claim is their claim. When we add supplemental diagnosis codes, this is health data analytics. We're using a diagnosis code to identify patients who fit into a hierarchical condition category so that we can create a RAF, a risk adjustment factor that is customized for each individual patient based on how sick each person is in totality, not just based off of what we treated this past year, but what are all of the conditions that we know that they currently have. And I think everyone could agree, no matter where you sit in the healthcare space, we will always do a better job if we know or are aware of all of the mitigating factors and circumstances that the patient has to be taken into consideration when we're making these choices in healthcare, or what gets approved, or what they might need, or what disease management program might work for them, and so forth. Okay, so I know I have a lot of meat supporters in the space. By my estimations, at least a third of the population of coders across the spectrum believe that meat is an important tool in risk adjustment. Sometimes they think that because this is the way that they were taught for fee-for-service billing, and they're very focused on following rules. By the way, meat is not really a rule, it's a tool that we created, but we'll talk about that in just a minute. But secondly, there certainly have been some national news articles that kind of come after health plans and say that they may have been adding diagnosis codes that they shouldn't because they weren't treated, or maybe that's not a doctor who treats that kind of problem, is the argument that's often heard. So let's just stop for a minute and talk about the MEAT acronym and where it really comes from. So I'm going to ask you to put your nerd hat on because it's going to get really very, very nerdy here. But MEAT actually existed long before risk adjustment was ever a thing. We actually used to use MEAT to teach providers how to choose the right levels of E&M service that they were choosing. You know, when they were choosing the levels 1 through 5 for the 992 codes, they couldn't choose a higher level of service just because the patient was sicker or had more conditions. That was the rule. You had to have monitored, evaluated, assessed, or treated the condition when you're selecting that 992 code. And the reason for that is because what you're billing for is the relative value unit of work that you provided on that date of service for the patient. So if you didn't treat these other conditions, whether they exist or not, as a provider, they cannot take credit for the condition in that particular visit or encounter because it wasn't addressed in the visit, right? And that's where the MEAT acronym really comes from. It really is a great tool for choosing the right 992 code. But the MEAT acronym is not a rule for the entire record or for the entire visit. And in fact, there's nothing stopping the provider from adding other diagnoses that were part of their medical decision making in their assessment or plan if they had to consider other treatments that the patient is on for these other conditions, or just the fact that they had this other comorbidity in the first place may have been part of their medical decision making. That doesn't mean that they can necessarily take credit for managing the condition in their RVUs or their 992 code, but they certainly could still report it. We just have had a long history in the fee-for-service world where procedure codes were king, that we ignored the diagnosis coding guidelines that told us to code for all coexisting conditions. And frankly, it was easier back then because there were a limited number of slots for diagnosis codes to appear on forms anyway. So better just to have the doctors focus on what was done on that visit, why, what was addressed, just keep it all simple. So the MEAT acronym actually was created and then utilized and started picking up momentum across the country, really. But diagnoses that are collected for risk adjustment purposes, those have nothing to do with normal coding operations or what the provider did for the patient on that visit. They are health data exercises that happen to use diagnosis codes. Okay, so just as a quick little highlight to remember, fee-for-service billing has been a golden standard for decades for transactions in healthcare for encounters or visits. So fee-for-service means that there's a service that was provided and there's a fee that goes with the service that was delivered to the patient, essentially. ICD coding guidelines have always told us to code for all coexisting conditions at the time of the visit or the encounter. We'll talk more about that in another slide. And then the E&M code selections are supposed to be based on what was done that day. And that's where that MEAT acronym really comes from. So when we talk about the MEAT acronym, this section that's highlighted in red ink, in quotes, is actually from what what I refer to as the green pages. They're the instructional notes in front of the E&M services portion of your CPT book. And it's under the section Determine the Complexity of Medical Decision Making. And the instruction reads like this. Comorbidities and underlying diseases in and of themselves are not considered in selecting a level of E&M services unless their presence significantly increases the complexity of the medical decision making. So this statement is really where the MEAT acronym kind of rose out of. This guidance is purely directed at the selection of the 992 code services, and it is not about how you're supposed to code for diagnoses. And we'll show you the diagnosis code guidelines in just a moment. I want people to understand that fee-for-service billing practices actually created incomplete diagnosis reporting. Because under fee-for-service billing, the diagnosis codes are only focused as how they relate to supporting the medical necessity of that procedure or service that was provided. And there's a limited number of spaces in the old forms, and then it just became commonplace to just focus on the ones that were monitored or assessed or treated or evaluated on that day, right? That means that there are other diagnoses for the patient that do exist that weren't treated that day that slide by. I always also point out to people that the diagnosis coding guidelines have always told us, in two different sections, by the way, to list any additional codes that describe any coexisting conditions in one section. And then in another section, they verbatim say the same thing, but they really put a lot of emphasis to say code all documented conditions that coexist at the time of the encounter or visit, and remember, and means and or require or affect patient care, treatment, or management. So they're saying list additional codes that describe coexisting conditions, and also be sure to list the ones who require or affect patient care, treatment, or management, part of your medical decision making. That's always been a part of ICD. We've ignored ICD for the reasons that I've given you on the previous slides. Now, as I mentioned, remember that fee-for-service pays providers a specific amount of money for a specific service that was rendered in the past. And it might be the most commonly used method of reimbursement, but this is changing with risk adjustment. We are seeing more and more providers being applied into a risk model in some fashion. Preferably, and best practices, honestly, it would be best if they tied that to quality of care measures there, or quality of care endeavors on the provider's behalf. And remember that fee-for-service payments, those can only increase by increasing the number of services, tests, visits, or procedures, or a duplication of services, or if the provider opens up longer hours, maybe they open evening hours and weekend hours to try to make more money. That's the only way that fee-for-service payments can increase. We also know that there are problems with fee-for-service because they create incentives to provide services that are reimbursed at higher rates, or to invent new services that are billed at higher rates. And it can often encourage overuse and misuse of services. And while it creates these financial incentives that are kind of negatives, it also creates disincentives to deliver services at a lower fee structure or a fairer price, or to provide services that aren't reimbursed at all. We have no insight into the quality of care that was delivered to patients. And when I say that we don't have insight into the quality of care delivered to patients, I mean, providers can actually be paid more in reimbursements from fee-for-service for poor quality, which caused a need for added follow-up visits or additional treatments or modifications to their original treatment. And many times these will go unnoticed under the radar unless people are really paying attention. Many payment reform models have been looking at ways to adjust payments for patient care based on the patient's need by diagnosis code, and while including quality of care measures, the attention to and management of chronic conditions. And that's really what risk adjustment is supposed to help us do. And remember that fee-for-service billing is done after a visitor encounter happens, and risk adjustment is collecting health data to become more prepared before future visits. Now, I also want to take a moment to clarify the difference between meet and tamper, because I happen to be the guy who actually created and trademarked the acronym tamper, and I did not create it as a purpose to challenge meat or to create a meat substitute or whatever else may have been said out there. The reason that I created tamper was because a lot of coders do not have a clinical background. And we know that meat doesn't really work for risk adjustment because we would be leaving out all of these chronic conditions that give us insight to patient needs and actually allow us to get ahead of some of these chronic conditions if we only know of them. But when you're reviewing records, you're not going to also then tell the coders to code for everything. And if they don't have that clinical background, how can they better decide when a diagnosis is presented in a list of sorts? Whether that list is called a past medical history list, or the title says ongoing problems, or at the top of the list it might say
active conditions, no matter what they may call it. This can vary from provider to provider and office to office. And what we do know true of all diagnostic listings is that they can get scrambled. You can have diagnoses that appear in a past history list that are still current, and you can have current diagnoses listed that are listed under a past medical history. And this is very confusing to coders. So the TAMPRA acronym was meant for one purpose only. It was meant to be utilized when coders are doing retrospective reviews of records and they are presented with chronic conditions in a list of sorts so that they can make a decision on whether they should pick up that diagnosis as an ongoing current condition or not. Remember that MEAT actually can falsely underreport actual diagnoses that patients actually do have, and that leads to the underfunding for those diagnoses in the future and a missed opportunity to get ahead of them in disease management programs. The diagnoses do not have to be actively treated if the data service is noted by the provider as a current or ongoing diagnosis. So the focus is not about what was treated in the visit. This is population health. The MEAT actually should only be used for the selection of an evaluation and management CPT code and not have any bearing on diagnostic coding. Now, I already mentioned that I trademarked this tamper tool, and I did that under Ion Healthcare. And you can credit myself or Ion Healthcare, it doesn't matter. But the purpose of this was not an alternative to MEAT. It's not a litmus test for the entire record itself. Is there tamper in the record, or there's a tamper in the data service? That would be using tamper in a wrong manner. The proper utilization of tamper is if the medical coder has a past medical history list or a current problems list, and they just have a listing of diagnoses, then was there any treatment, assessment, monitoring, medication, planning, evaluations, or referrals done related to the diagnosis? Now, out of all of those acronyms, probably the most common one that we utilize successfully is the medication one. And that is because oftentimes, the patient may be on ongoing pharmaceutical support for a chronic condition. By the way, the insurance company is paying for those prescription drugs every month for that condition, and they might be doing well on the prescription, but just because they're doing well on the current treatment plan and are going along pretty well, that doesn't mean that we should stop collecting that as a chronic diagnosis, because the patient really does still have that condition, and that can be evidenced by certain medications where that's the only thing that that medication is used toward. So just as a final recap, MEAT is only useful for fee-for-service E&M coding based on the relative value units of work that are being reported, because you have to have monitored, evaluated, assessed, or treated those diagnoses in order to choose that higher level of service. It can't be just because they have these other conditions. That's where MEAT is meant for. And it should not be applied as a requirement for risk adjustment modeling. That's just going to leave a lot of important healthcare data analytics behind. Now let's shift gears just a moment and talk about the challenges of building coding teams, because boy, do we know about that. Finding coders with the proper experience can be really difficult. Finding coders without misguided perceptions, and especially finding coding leaders with management skills, is especially hard. I'm going to talk a few minutes about these and talk about some of the evaluation techniques that we recommend as best practices when we're building coding teams. The first thing is it's certainly helpful if the coders have some experience and that they have their CRC or Certified Risk Adjustment Coder credential. However, you also have to keep in mind that if they've worked for a lot of other health plans or other vendors in this space, they may have learned to code in different ways. In fact, I can promise you that if they've worked for at least 3 different coding vendors or health plans, they probably have coded at least 3 or 4 different ways between them. That's because no one is coding with consistency and following the same guiding principles or practices. Some are restricting their diagnostic collection with the MEAT acronym, and others know that this is wrong because if you read the RADV and the HRADV protocols, we are supposed to include diagnoses that are in lists. Those are absolutely approved in RADV and HRADV. We're not auditing those encounters. When we do a risk adjustment data validation audit or an HRADV for the HHS side, when those data validation audits come through for risk adjustment, we are not auditing the past encounters or visits. That's not what we're doing. We are auditing for the diagnosis code collection to make sure that the risk adjustment factor scores, or RAF, are correct for each individual patient, that we have properly represented what all of their chronic conditions are so that we have a solid RAF score for each patient. Now, when you're picking coders, we recommend that you review the candidate, look at their social media, look at where they went to school for their coding education, look to see if they're involved in any of their coding practices, look to see if they have a LinkedIn page, do they have a professional page. Look over their resume, of course, but we always say that it's very common for people to have worked in different places rather than stay in one place in modern times. But when you do find gaps in employment, it's important to ask questions about what happened with that and if they've had any problems in the past, not only with their coding performance, but if they've had any problems interpersonally or socially with some of their coworkers. We always recommend pre-employment testing, and the pre-employment testing should be a combination of questions that not only test their coding ability, but also test the character and the integrity of the person to make sure that they're going to represent your organization in the way that you'd like, and to make sure that they're critical thinkers. It's super important to have plenty of questions on your pre-employment test questions that have really, really deep details to see if they're paying close attention to those details. And then ultimately, no matter what their scores turn out to be, the big question is, are they teachable? Do you think that you can work with them? And are they going to be a fit for your team, organization, or group? So let's talk just for a moment about retrospective chart review efforts. A few key points that we'd like for people to remember is that HIPAA does not apply overseas. Offshore coding, in our experience, frequently has a 40% error rate, and that is not about coding skill or clinical knowledge as much as it is about the process of how they are instructed to code. They are not encouraged to be critical thinkers in a lot of these companies. And you should be aware of the marketing techniques of these other countries and how those chart fee differences are applied. Certainly, there are large volumes of medical records that are being retrospectively reviewed unnecessarily every year. In our early risk adjustment days, when we first started doing this type of work, retrospective review was much more targeted and smaller in nature, and we can get back to that if we use some smart analytics to try to help minimize these overall program costs. Okay, so how did we get here? And by here, I mean where we're sitting in 2022. Well, let's look at the history of how we arrived here. First of all, it's been a little messy. I mean, we have this new risk adjustment modeling for population health released in 2004 or so, right? And for Medicare Advantage. And of course, they're modeling a little bit off of the CDPS that were released way back in the 90s. And then there's a difference in the payment in the model for the health plans, right? I don't know if you know this, but they didn't get 100% of the value of the diagnoses until 2007. And of course, the models have to be calibrated every year. And so sometimes things change in their categories, or they might be changed from a Part C to a Part D, or their risk adjustment factors might be altered in some way. That's part of how the system is supposed to work, with variations and calibrations each year as we look at data and learn more about the population of people in this country. A lot of people accused health plans of gaming the system, right? They weren't gaming the system. In fact, they knew that they needed to do these retrospective reviews because a lot of diagnosis codes were not going to come over on a regular claim because the doctors are not treating every single diagnosis that the patient has. The patient comes in with 1 or 2 complaints typically. And if they have more than 2, oftentimes the doctor will make another visit for the others because they have to have enough time to address each complaint. There are a lot of things they have to do for each diagnosis. And, by the way, providers couldn't possibly be expected to document every single diagnosis and every visit or to be the savior of all of this data or information because they're quite pressured already. I've always thought of the primary care doctor as my favorite doctor and really the unsung heroes of healthcare, if you think about it. I mean, they're the ones out there organizing and coordinating care for their patients. They're the ones who are getting approvals for referrals and medications that the patients need while filling out forms for patients from physicals and dealing with legal issues. I mean, it's just a never-ending job. And it's amazing that they even have time to see patients, honestly, with all the paperwork that they have to ruffle through. Then EMRs, right? And the struggles that come with the EMR systems for them. So, why are health plans accused of gaming the system? Because all of these new diagnosis codes are getting reported because of their retrospective review efforts and also the more specificity that's offered in ICD-10 that wasn't as specific in ICD-9. And then we had these national news audits that came out, and they were quite scary for people. We have interventions that suggest that health plans were overreaching because those are conditions that weren't treated in that year. I can promise you that if they said that it was because they weren't treated in that year, it's because that they moved forward in the case without fully understanding the intent of risk adjustment and how it was supposed to work. And that's merely following what the established fee-for-service rules always were and looking at through the lens of if you were a billing provider instead of a population health program. There was this big movement because of this to try to get providers to put more documentation into their records in the assessment or plan, if at all possible, because those would not be as highly scrutinized, obviously. And that puts an added layer onto the provider of stressors that really shouldn't be there. Providers have enough on their plates. Yes, we should do clinical documentation improvement with them. Yes, we should talk about being as specific as possible in diagnosis reporting. And yes, we should ask them to include all the conditions that were part of their medical decision making when they report the diagnosis code, but also be sure to only count the ones that you treated when you're choosing your E&M level of service, as you always have. And then this whole meat phenomenon just complicates matters even more because we have people in the industry who are following it, we have people who are not, and there are people within the same organization where they're coding differently within the same company. So our goal here is to bring everyone together and recognize how we got here so that we can learn how to move forward by applying the right standards so that risk adjustment can do what it was supposed to do for us, as it was intended to be used as a tool to help us improve the healthcare delivery.
Okay, so let's talk about applying national standards, which is what we're doing here at the Risk Adjustment Integrity Group of Advize Health. We want to make sure that we establish and hold strong to national standards so that all health plans, all issuers, all accountable care organizations, providers, vendors in the space, no matter from which tribe that you come, that everyone is following the same standards with consistent coding practices. Consistent coding practices nationally is what is going to make or break risk adjustment modeling. If one issuer fails to report all known current diagnoses, then that issuer then loses funding for any unreported diagnosis that the patients have for next year. And if you think about it, that's just crazy, right? We're not going to report this because it wasn't treated on this day in the past, last week or 2 weeks ago. But then that actually affects the payment for not this year, but next year for the health plan. So the diagnosis then falls off of their radar. So we then fail to pull in these actual diagnoses that could be better managed and improve patient health outcomes. And it's also important that health plans follow the same collection methods to be balanced for risk adjustment to work properly, especially in the commercial side of the house where you have a zero-sum balance where everyone has to share from the same pot of cash flow to take care of American citizens. And so the health plans who have the sicker patient populations by chronic conditions are entitled to a larger portion than those health plans who have healthier patients. So it is very important that we apply these national standards so that these risk models can work in the way that they were intended to work. These modified capitations really do require national standardization. Now, while it is true that risk adjustment, which is a population health tool, is a form of modified capitation, this is not about how the doctors are paid. This keeps the current estimates of average cost per member per month, but it narrows that actual need or cost by individualized RAF scores or risk adjustment factors. So patients who are healthier are going to have a lower RAF score, and patients who have more chronic conditions are going to have a higher RAF score. And this is based on all of their known current diagnoses. It's what are you as a person? If you had a barcode scanner on the back of your neck, what diagnoses would pop up that we need to be concerned about with you? What do you carry around with you day to day? The patient with the multiple chronic conditions or diagnoses are going to cost a lot more, and we know approximately how much exactly. In fact, the people who developed these models, they use clinicians and statisticians and very highly experienced people with doctorate level degrees and master's prepared degrees where they look at what they think things are going to cost, and they look at how they're going to spread out the hierarchies and categorize these in a way that makes sense clinically and takes into consideration what types of treatments or modalities are most frequently needed for each of these types of patients. I mean, they didn't just willy-nilly throw this together. There was a lot of thought behind this. These models enable financial forecasting so that we have the funding available to take care of the patients that are within the population group. Now, some of you may have seen this slide before because I certainly have used it in the past. I've created a new one for this particular session that is a little different slant. I used to use this to show 3 different columns where I would show no conditions coded, and then the middle column would be some conditions were coded, and then the far was all conditions are coded. And it was really trying to illustrate the importance of having coders who were highly trained in risk adjustment, who were detail-oriented and critical thinkers, because we want to make sure that we're collecting all known conditions each year. But I actually kind of turned this around on purpose to kind of help illustrate what was really happening right now and the how we got here portion of this, which is the middle column represents one health plan that we call Health Plan A, where some conditions are being coded, but some are being left behind. And then we have the far right-hand column where all conditions are being coded at a different health plan, or you could change health plan for vendor even. And so in some cases, all conditions are being coded accurately, and in some cases, there are many conditions being left behind. This is not about the payment for the providers. This is about the payment to the health plan so that they're able to reimburse providers for their claims. So when you look at the total RAF scores at the bottom of these 3 columns, you can kind of see how the RAF score increases based on the severity of illness that the patient carries. It's not about what they were treated for in the past. It's about what do they have right now, because we need to be prepared not only for the financial needs of the manifestations or complications that we know are likely to come from this combination of diagnoses individualized to this specific patient, but we also would like to have an opportunity to be more proactive on these complications or diagnoses so that we can avoid some of the complications or manifestations that may come. If we can get them enrolled in certain wellness programs for certain diagnoses or identify new wellness programs that might be needed in certain geographical areas, then that allows us to be more effective in healthcare delivery. Okay, so let's talk about some important things like some secrets and tools that we could share. So First of all, let's remember that there is an importance of group training throughout the organization or entity. That's everybody, to include your analytics and reporting people, your C-suite people, your IT people, and your coders, because everyone who touches this data has to be familiar with and understand the data with which they are working. Secondly, you've got to understand how aberrant coding happens, how you can get different results from different organizations, or if you don't follow the same standards or policies, how the coding is going to be very disjointed and inconsistent. Also, we recommend that you have tools that help coders. Your policy is your policy, and the policy should be in congruence with the intentions of risk adjustment as a population health tool. However, there are tools that you can give to coders. For example, this PLL that I have in parentheses. If you don't already have a permanent lifelong conditions list, I recommend that you create one. And by the way, if you reach out to us on our info and ask us for a copy of ours and schedule a meeting with us to talk about what we might be able to do to help you, I'll make sure that you get a permanent lifelong conditions list from yours truly that is up to date and recommended to use. We also recommend using a cascade training approach. That means that you don't just train everyone in a classroom and they sit there and they understand and they absorb. You identify leaders in your organization who are risk adjustment champions. That could be coders, that could be champion physicians, that could be champion administrators, but they should be people who are very familiar with the models and understand the topics and the concepts that we've talked about today. And then also remember that when you're choosing coders, or whether they be temporaries or using temporary services for coding exercises, just because they're a certified coder, or just because they even have a CRC in today's day and age, does not mean that they're familiar with all of the concepts or how coding for risk adjustment is different from fee-for-service billing. So it's important that everyone is trained, and if you're not doing upfront training, you definitely should be, and you have to stay vigilant on your quality assurance side to make sure that the coding is consistently reported so that we can all be evaluated and compared against one another more fairly. When coders are not trained consistently, they will code differently. And both the health plans and the patients that we all serve are the ones who ultimately pay the price for that. So on the topic of unifying risk adjustment educators and those leaders who are out there with us, as I mentioned before, it's important that providers are involved to a point, such as diagnosis specificity and reporting all of the diagnoses that are a part of their medical decision making. But let's all be honest. What we really need here is programs that are identified that reward providers for quality of care toward these diagnoses. And it's not that they achieve certain results, but that they demonstrate their attempts, and that some patients are going to be non-compliant, and also each patient responds differently to various treatments or plans. So we should reward providers for their efforts when they develop new treatment ideas that improve patient outcomes, and any bonuses to reward providers should be about those things and not about reporting diagnoses. Clinical documentation improvement programs should also include the review of EMR standards. I know that some EMRs have an HCC next to certain diagnoses, but this is actually unnecessary and could be viewed as leading the provider to choose a diagnosis. The EMR systems do this, and they use data that's oftentimes old data because they can only rely on the old CMS Medicare Advantage model. But if the only HCC that's appearing in parentheses is the CMS MA model from last year, then we're leaving out the CDPS model for Medicaid or whatever the state may be using. And then secondly, we're leaving out the HHS model HCCs. And frankly, it's hard to calculate those HCCs. In the ACA model, there are 15 different potential versions of risk adjustment models because each value is different based on age group and metal level. It's not something that people can be expected to memorize. So yes, the HCC information needs to be in there if possible, but it's more of an administrative thing, and I don't know why we're even showing the doctors what risk adjusts or not, unless we're trying to encourage them to pick them, which is kind of a bad look, right? We also want to make sure that these EMR systems are not just programmed to push the commonly used diagnosis codes to the top of a drop-down selection box, or chooses those that only have the HCCs beside of them as the first selected. That could also be viewed in a negative light if you are audited. But remember that provider documentation itself is not going to be the only saving support. Supplemental diagnosis collection is paramount to the success of a population health program like risk adjustment modeling. And the Risk Adjustment Integrity Group at Advize Health, we are here to help everyone in the space so that we can get together on this. I really believe we can make a difference and we can improve healthcare delivery, but first and foremost, we have to be on the same plane. Now, being committed to risk adjustment's purpose and design includes a few things. First of all, a standardized collection of all current diagnoses, not just those that were treated, but all which are current at the time of that visit or encounter. Secondly, a compliant, suspecting, querying, and provider communications policy and procedure is very important. And providers should never be pressured to add diagnoses, but they should add all which were part of their medical decision making for the visit, as well as any specifically treated or addressed in the visit. Any other chronic conditions can be found through retrospective review and supplemental diagnosis code collection toward HCC scoring. Everyone has to understand that this is not really coding. When we collect those current diagnosis codes, we are collecting data using an ICD code as a vehicle that is then dropped for an HCC value. It's not really coding as much as it is health data metrics for the purposes of a prospective population health approach to healthcare delivery. This is supposed to be different. It's supposed to feel different from what we're used to doing in fee-for-service and E&M coding. It's a different way of looking at healthcare delivery to get ahead of those problems. We just merely have to trust in risk adjustment's design. Keep in mind that diagnosis codes are dropped out of the risk model from time to time, or changed in their hierarchy, or changed into which family. And sometimes they're completely changed as far as their scoring even. And remember that what we collect in risk adjustment purposes, it doesn't have anything to do with those past visits. I mean, yes, it does have to come from face-to-face visits by approved provider types, but the approved provider types, incidentally, are not just doctors. They include mid-levels and physical therapists, occupational therapists, licensed clinical social workers, nurse anesthetists, and more. How did CMS make this decision? It's because these are masters prepared or higher providers who are recognized treating providers who are allowed to make diagnostic statements in the course of their work. They either treat those conditions or they have to be aware of those conditions in order to treat the ones that are of their specialty. So two main things to keep in mind. Not only does MEET not apply for risk adjustment for that date of service, but secondarily, it doesn't matter if the diagnosis came from a different type of provider who would not normally treat that condition. We're not auditing that provider's note. We are auditing to achieve a recognized risk adjustment factor score for each individual patient based on all of their known current chronic conditions. Now, I know that there are some people out there who have voiced a concern that they feel like this is a personal opinion and that they disagree and that they believe in fee-for-service rules, etc. I'm just going to leave you with this thought. I understand people who are uncomfortable when something is new and different. I certainly do. And it's sometimes when something's different from what we're used to, it makes it the hardest thing of all. I can assure you that when I first got into this space in risk adjustment,
I worked really hard to contact and talk with people who were at RTI. I read their white papers to understand why they developed the model and what they intended to do with the model. I spent many, many hours pouring through those CMS manuals, and I can tell you that I have worked directly with people at CMS and HHS alike and have been able to not only collaborate with them, but also get them to answer questions for me as well. And so what I'm teaching you here today, what we're sharing with you, is not an opinion. It is factual. It is truly how risk adjustment modeling was intended to be utilized. And if you have any questions, we would love to work with you to help get everyone on the same page. Our main motto at the Risk Adjustment Integrity Group is to keep risk adjustment on track, and there are several ways that we can offer to help everyone do that. Remember that we are a national advisory for health plans, risk adjustment vendors, providers, accountable care organizations, and we wanted to reach out to our risk adjustment educators and leaders first and foremost to try to help to make sure that we're all following the same protocols and guidances.